My name is Gráinne Healy and I will be chairing our session this afternoon. I want to welcome you all to the launch of the Croí MySla report, sharing outcomes from a digital cardiovascular prevention and rehabilitation programme delivered during COVID-19 pandemic. A link to the report is now being published in the chat box for your information. In September 2019, Croí, the West of Ireland Cardiac and Stroke Foundation, was awarded Sláintecare integration funding to develop an innovative community-based interdisciplinary lifestyle intervention known as Croí MySla. It aimed to improve risk factors across a wide spectrum of chronic diseases, including cardiovascular disease. This innovative project, grounded in the Sláintecare principles of right care, right place, right time, and the right team, sought to support the delivery of services using digital tools to focus on prevention, community care, and the integration of care across health and social care settings. Over the next hour and a half, we will hear from those involved in the creation and delivery of the Croí MySla project, cardiologists, CEOs, program managers, patients, and those involved in overseeing the development of digital transformation internationally and at the HSE. We'll also be focusing on the key impacts of the programme, with a particular emphasis on the outcomes for patients, who will tell us how their involvement in the digital cardiovascular prevention and rehabilitation programme has affected their lives for the good. We're looking forward to our panel discussion towards the end of the session. So if you wish to make a comment or ask a question of any of the panelists, please do send them in using the Q&A function, and I will be happy to put the comment or question to the guest and get the answers for you during the live broadcast. The Croí MySla project was developed, delivered, and had to pivot on occasions during the COVID-19 pandemic. But despite the challenges facing a new initiative in a time of pandemic, this project, in terms of health outcomes, patient engagement, and the implementation of lessons learned by the team, has allowed the project to leverage the outputs from the programme as part of the local and national efforts to address cardiovascular disease, one of the most pressing health service problems we face today. To kick off our session then, I am delighted to present to you a short message from our Minister for Health, Mr. Stephen Donnelly, TD.
Good morning. I'm delighted to be able to open this event for the Croí MySla outcome report, showing how digital health technologies can be used to optimise cardiovascular disease prevention in Ireland. The vision for our future health service is universal healthcare, that right through their lives people can access the care they need when they need it. Croí MySla programme is a leading example of how this looks in practice. My department's integration fund provided funding to Croí to offer a patient-centred way of delivering chronic disease prevention care through a virtual platform. This makes it accessible for people from the comfort of their own home. The challenges our health service has faced over the past 2 years show how shifting the model of care closer to home is now more important than ever, freeing up capacity in our hospital services. As people age, they're more likely to suffer from chronic illness and disease, including heart failure, with lifestyle factors also playing a significant role in the onset and management of disease. Effective management and treatment of these conditions requires continuous care, including embedding self-management and support. The Croí MySla programme has empowered people to better manage their own condition at home by providing them with education and the support to monitor their health and identify risk factors quicker. The outcomes that will be shared today provide really important learnings for practitioners working with cardiovascular disease. Once again, my sincere thanks to all involved in the Croí MySla project for developing interventions which are supporting people to optimally manage and improve cardiovascular risk factors. Thank you.
And thank you, Minister Stephen Donnelly, for your message and your sense of how well this initiative sits within the overall move towards community-based self-management and the use of technology to support such moves, leading to improved outcomes and efficiencies. So let's move on then to our guests that we have for you this afternoon. We have had a few changes to our panel of experts, but I'm delighted to welcome our first guest this afternoon, Professor David Wood. Professor Wood is a world-renowned leader in cardiovascular disease prevention and is the Director of Science, Strategy and International Relations at the National Institute for Prevention and Cardiovascular Health. Professor Wood is a former president of the World Heart Foundation and an adjunct professor of preventative cardiology at NUI Galway. A warm welcome to you, Professor Wood. Thank you for joining us this afternoon.
Thank you.
May I ask you, first of all, maybe to tell us some of the background to and the compelling rationale for cardiovascular prevention and rehabilitation programs?
Well, the cardiovascular disease is really one of the major causes of disability and death in Ireland and indeed worldwide. And we know that for patients who present with a heart attack or a stroke or hardening of the arteries in the limbs, that a comprehensive prevention and rehabilitation program will reduce their risk of the disease recurring, will reduce the need for revascularization, will reduce hospitalizations, and importantly, from the patient's perspective, will lead to an improved quality of life and life expectancy. And yet, despite that compelling evidence, what we see in everyday practice falls far short of the standards that we would expect in a modern preventive cardiology program. And the Ireland Aspire survey led by Professor Bill McAvoy from the National Institute for Prevention and Cardiovascular Health and conducted under the auspices of the Irish Cardiac Society, examined over 700 coronary patients from 9 hospital sites around the country and found the most extraordinary variability in access to and participation in such prevention and rehabilitation programs, and also the most extraordinary variability in terms of the management of these patients between hospital centres. To give one example, there was a difference of 64% in referrals to and attendance at cardiac rehabilitation programs between the best and worst centres. And another example is the control of blood pressure. For patients presenting with an acute heart attack, their control of blood pressure was very much better than patients presenting with chronic coronary disease. And yet they all have atherosclerosis. They should all be treated in exactly the same way, but the standards of care fall well below what we would expect from the current guidelines.
Very interesting. And tell me, the emphasis for Croí MySla is on prevention and rehabilitation using a digital cardiovascular model. How well has it worked in your view?
Well, it's important to see the context for the Croí MySla program, and the Irish Association of Cardiac Rehabilitation really did an excellent job in surveying the status of rehabilitation in Ireland. And what they found was very disturbing. They found that there was a waiting list of almost 3,000 patients for these programs, an increase of 54% since 2013. Staffing was reduced by 40%, and 40% of patients were waiting more than 3 months to be seen. So this is a real crisis, I think, in terms of the delivery of prevention and rehabilitation programs. But in Ireland, there is this very important transition from hospital-based services to community services, a transition which I think is very welcome indeed, and which the Croí MySla program fitted the bill, because that program, nurse-led, nurse prescriber-led, interdisciplinary, involving dietitians and physiotherapists, was able to deliver a comprehensive lifestyle intervention, but also address the management of the other major risk factors like blood pressure and cholesterol and glucose, and as importantly, ensuring that the appropriate drugs are prescribed and up-titrated and patients adhere with these medications. And the arrival of COVID-19 really accelerated the transition of Croí MySla to a virtual delivery program. And actually, the outcomes of that virtual delivery have been as impressive as the traditional face-to-face delivery that we had before. So this has been a big step forward.
Very good. Thank you for that, Professor Wood. And we'll return to some of those maybe larger comments looking at this in the context of international research and work that I know you're also involved in when you come back as part of our panel later in the broadcast. So thank you so much for that, those introductory remarks. Before I go to my second guest to hear about the programme and its key outcomes, I want to bring you some personal testimonies that we've gathered in animated video format. Patient experiences really give us insights into the patient view of participating on the project and its impact on their lives. Let's hear from them now.
Meet Jerry, age 67. Jerry had a heart attack in 2019. He thought it was indigestion and didn't go to his doctor for 5 days. He was sent immediately to Galway University Hospital, where he had 2 stents inserted. Jerry is a former lighthouse keeper and lives in a very rural area in County Mayo. Sometimes Jerry can't leave his house if the tide is high. By accessing this cardiac rehabilitation program online, Jerry didn't need to worry about travelling or tide tables and could focus on his heart health instead. Jerry was able to log into Zoom on his laptop for the exercise classes and completed the MySla program through the online platform. David, 58, from Sligo, is living with atrial fibrillation, an irregular heartbeat. In 2019, he needed 3 stents due to blocked arteries. After his surgery, David took it easy, with his family not wanting him to exert himself. David felt tired all the time and unfit. He knew he needed to take control of his heart health and push past his comfort zone. David knew he wasn't living the life he was supposed to be. Sitting on the couch, just watching TV, he kept thinking, is this it for me? The Croí MySla program gave David back his confidence. It showed him how to drive and motivate himself, and he was so happy with that. David said he didn't know anything about the medication he was on, but the Croí MySla health team helped to educate him. Jonathan, 38, from Westport in Mayo, suffered a heart attack 1 year ago. Jonathan's baby boy, Shay, was born just as Jonathan started the MySla program. The online program delivery meant less travel time for the new dad in Mayo and more time with baby Shay. Jonathan's mental health suffered after his event, but the Croí MySla program has helped to lower his anxiety levels and give him back his confidence.
So 3 very impactful stories there, and we will hear more from Jonathan Walsh live, as they say, in a short while. My next guest this afternoon is Irene Gibson, and Irene is a cardiovascular nurse specialist and previously was Director of Programmes at Croí, the West of Ireland Cardiac and Stroke Foundation, where she led the development and implementation of Croí MySla. She is now a Health Research Board Sphere Scholar and is evaluating the programme as part of her PhD in chronic disease prevention at the NUI Galway. Irene, you're most welcome. Irene, I wanted to ask you to really briefly describe the programme and to then focus on the impacts for patients, for clinicians, and overall prevention and rehab impacts. And I know you have some slides to help us through the presentation. So over to you, Irene, and off you go. Thank you for joining us.
Good afternoon, everybody, and thank you, Gráinne, for that introduction. And I'm really delighted to be here today and very privileged to be presenting the outcomes of the Croí MySla programme on behalf of the Croí Health team. Having just watched that lovely video animation and hearing Jerry, David and Jonathan's stories, I think it really drives home the real impact and burden that cardiovascular disease has on people's lives and how it affects not just their physical health, but their mental health and overall quality of life. And really, I suppose, highlights the importance of providing people with the right care at the right time. And in essence, this is really what the Croí MySla programme is all about. Professor Wood spoke to some of the challenges that we have in prevention in Ireland. And these challenges are ongoing and have existed pre-COVID. But when COVID hit, it caused incredible disruption to cardiology services, but in particular cardiac rehab, when over 70% of cardiac rehab centres were closed in Ireland. So really, the Croí MySla programme was about providing that accessible care, evidence-based care in a very comprehensive way and in a timely manner at a time of, I suppose, increased vulnerability for cardiac patients. The programme itself was designed by a specialist interdisciplinary team, which involved a cardiovascular nurse prescriber, physiotherapist, dietitian, with the support of a cardiologist, administrative support, and also an e-learning technologist. The programme was delivered over a 12-week period and was very much modelled on the evidence-based MyAction programme. It had a number of core components which focused on lifestyle modification, medical risk factor management, along with focusing on psychosocial health and the prescription of cardioprotective medications. And of course, central to all of that was supporting health behaviour change. And the programme adopted very much an outcome-focused approach where audit and evaluation were key to the delivery. And of course, with the emphasis being on supporting long-term maintenance of behaviour change. In terms of what it looked like, the patients were referred from a number of centres across the west of Ireland. And when they were referred, they were invited to attend for an individualised assessment with the team. And this assessment was conducted online using Zoom technology. And once that assessment was complete, they were invited to enroll in the programme and were given access to a bespoke web-based platform, which was designed by the team. This platform hosted a wide range of interactive education resources, including pre-recorded videos, as well as embedded Zoom links to weekly live sessions, which involved a supervised exercise programme, and also health promotion workshops, which focused on a wide range of topics, including stress management, understanding what cardiovascular disease is, the importance of healthy eating, looking at, supporting understanding food labels, and really practical advice for cardiac patients. Key emphasis of the programme was on promoting self-management using very specific behavioural change techniques and providing patients with self-monitoring tools. So for example, patients were given blood pressure monitors to support home monitoring, were given Fitbits to help support track their physical activity levels, were provided with a workbook to support with goal setting and also to track their overall progress. Central to the programme was nurse prescribing, and we were very fortunate to have a nurse prescriber as part of our team who was very much focusing on the delivery of a programme to very key targets across both blood pressure and cholesterol, working closely with both GPs and also with pharmacists. And throughout that process, there were ongoing weekly team meetings focusing on the patient's progress and very much individualizing care, albeit while it was being delivered online, we were very keen to mimic as much as we could the face-to-face interaction. In terms of who attended the program, well, as I mentioned, we received referrals all over from various different cardiology centres and cardiac rehab units in Galway, Mayo, Sligo, Limerick and Donegal. And I think that's one of the key advantages of digital, is that it does increase your reach. Of those who were referred, 81% were male, which really reflects the proportion that are referred to cardiac rehab. The age range varied from 35 to 84 years, with the average age being 63. And 86% were living with a family member. In terms of patient diagnosis, and not to get too medical here, but this is really to give you an idea of the various different, I suppose, cardiac conditions that people were referred to the program with. Almost half of patients had what we refer to as percutaneous coronary intervention, which is really stenting. 30% had a heart attack and had this intervention. 8% had heart valve disease. 7% had bypass surgery. 3% had a heart attack and were being medically managed, and 4% had heart failure. And again, this is very reflective of the type of patients who are referred to face-to-face cardiac rehabilitation programs. When we started this program, when we conducted our individualized assessments and looked at all of the various different risk factors at baseline, I think one of the things that really concerned us at the outset was the very poor risk factor profile of our patients. And you can see this on the screen here in front of you, that, you know, almost 90% of our patients were not meeting the physical activity targets. Over 70% were either overweight or obese. 76% were not meeting the recommended blood pressure targets, almost 90% not meeting the cholesterol targets. Anxiety and depression were very prevalent. Probably on a more positive note, the prevalence of smoking was quite low, so that's a good news. But I think this really highlights, I guess, the challenges we have when it comes to prevention and the state of play. And these outcomes and I suppose lack of control of risk factors almost mimic what we've seen in the iAspire survey. And I guess in many ways, it wasn't surprising that 23% of these patients had had a previous cardiac event. So the recurrence of another event with this group of patients with this risk factor profile is very, very high. When it came to evaluating the program and looking at, you know, how do we measure success, there were a number of key things that we looked at here. Of course, it was very much underpinned by, I suppose, the targets that were set out within the Integration Fund grant agreement. We were very keen that our audit and evaluation focused on benchmarking against best practice guidelines, which in this case were the European Society of Cardiology guidelines for prevention. But of course, how were we going to do this? Because we were delivering this program face-to-face, or we were delivering this program online, and didn't have the opportunity to engage with people face-to-face and measure things like blood pressure and all of the things we would ordinarily do in practice. So this was a really collaborative approach where we worked with GPs, we worked with the cardiac rehab centres, and most importantly, the patients themselves played a really vital role here in measuring their own blood pressure, in completing online questionnaires, in also linking in with their GPs, who at a time were not wanting to see patients for the safety risks associated with COVID-19, but who supported with doing things like bloods and so on. And when we looked at audit and evaluation as part of this program, while there was a strong focus on clinical outcomes, we equally wanted to look at how acceptable this program was to patients and also to the healthcare professionals who were delivering the program. And we were very, I guess we were very fortunate to have a lot of input from our Croí public and patient involvement panel, who really contributed a lot to the evaluation of the program as well. So just to give you an idea of, I guess, firstly, the uptake and retention rates. So of those who were referred to the program, there was a very high uptake rate. Over 73% attended the initial assessment. Of those, 97% enrolled in the program, and 85% stayed on the program till the end, with the average attendance being 9 to 10 weeks per person on the program. The main barriers to participation related to things like poor digital literacy skills, just very plainly and simply not being comfortable with using the technology. For many people, inadequate IT support was a key factor. For example, many people did not have broadband, which was a key issue. And many of the rehabilitation centres reported that they didn't refer patients because the patient did not have broadband. So it wasn't a willingness or a lack of willingness to engage in the technology. It was just they did not have the infrastructure. And of course, there were other health issues and family commitments that people had in terms of caring responsibilities for relatives and so on. So now I'm just going to briefly talk you through the outcomes across three main areas: lifestyle, medical, and also looking at psychosocial health. So from a lifestyle perspective, we looked at physical activity. And what we saw as a direct result of the program, and probably reflective of the input from the interdisciplinary team and the structure of the program, was an improvement in physical activity levels from 14% to 82%. What does that mean in terms of reductions to cardiovascular events? Well, very, I suppose, significantly, it leads to a 20 to 30% reduction. And we saw those improvements. We benchmarked them against achieving recommended targets. From a dietary perspective, we looked at adherence to the Mediterranean diet, which we know is cardioprotective. We saw a mean increase from 5.2 to 7.3. And again, here, what we were looking for was an optimal score greater than 9. But this level of increase is associated with a 30% relative risk reduction in total mortality, cardiovascular mortality, and also cancer. And significantly, we saw a mean weight loss of 2.7 kilograms. From a medical perspective, we looked at the proportion achieving the recommended blood pressure targets. And what we saw was an increase from 24% to 68%, with a mean systolic reduction of 19.5 millimeters of mercury being observed. And again, what does this translate to in terms of cardiovascular benefit? Well, it results in a 17% reduction in risk of coronary heart disease and a 27% reduction in stroke. From a cholesterol perspective, we saw an increase in those achieving the recommended LDL targets, increase from 14 to 41%, with a mean reduction of 0.76. What does that translate to in terms of cardiovascular risk reduction? 15% reduction in overall cardiovascular mortality and non-fatal myocardial infarction. And then finally, looking at psychosocial health outcomes. And here we use the validated hospital anxiety and depression score. And what we observed was a reduction in anxiety levels from 40% to 23%, and a reduction in depression levels from 22% to 10%. And this was very significant. And I think one of the things when we look at all of these outcomes, and one of the things that we were really astounded by was how comparable they are to the outcomes that we see on traditional face-to-face programs. And I guess this really gives us a lot of encouragement, really excites me as a healthcare professional as to the potential that digital health has, and gives me confidence that really around the opportunities that digital health presents for the future. Today's discussion really is about harnessing and how we harness digital health. What's, of course, critically important to this is understanding the patient perspective and how important programs or how acceptable programs like this are to patients. And as part of the Croí MySla program, we've been very fortunate to collaborate with the Health Behaviour Change Unit at NUI Galway and do some research on this, which has been led up by Dr. Una Mead. And through a series of interviews that they've done with patients, there are a number of factors that are identified at both the personal level and program level that are important to patients when it comes to looking at the acceptability of these programs. From a personal perspective, the relationship to technology is important. While many patients said they were really anxious about engaging with the technology, they felt the support provided by the Croí team was really important, particularly the administrative support and the assurances that they were given. A lot of them spoke about concerns they had regarding privacy, their level of comfort, about being on a Zoom call like today, their faces being on a screen, and concerns they had there. They also spoke about their safety and risk concerns, but again felt that a lot of these were very much mitigated by the Croí team and the structure of the program. In terms of the program factors, they felt that because the program was very much individualized themselves, they really valued the one-to-one sessions with the team. They felt the messaging and the platform itself was very much designed to be focused on their disease condition, and that was important to them. And also the credibility of the program. And I think this highlights a really important fact that, you know, often when we think of digital health, or we go online and we look at various different things, we don't know how these interventions are being developed, by whom. The degree to which they follow evidence-based guidelines is often very unclear. And this was something that the patients felt was really, really important. So there was very much a balancing act going on when people were looking at the acceptability of the program. And I guess the key message here is that what we're identifying are a number of factors that we do need to take into account when we're designing such programs. There is no one size, that fits all. We're not going to keep everybody happy, but I think it's really important that we look at these factors and take them into consideration. From a healthcare professional perspective, I guess there were a number of things that were identified when it came to looking at acceptability of the program, and healthcare professionals identified factors at a patient level, at a systems level, and also at a professional level. And I'll just briefly touch on one or two of these. At a patient level, they really felt that this program offered patients the opportunity to engage in an intervention that they otherwise would not have had during COVID. They felt that these type of interventions have an opportunity to address some of the challenges that we have in prevention, and the general challenges regarding uptake and accessibility of cardiac rehabilitation programs in Ireland. When it comes to the delivery of these programs, it's really important that they're individualized to the patient. And that was a very key factor in this program, that they're very much quality focused, focusing on that standardized approach to care, that they're evidence-based, safety being important, particularly when you're looking at the prescription of exercise. At a professional level, healthcare professionals very much felt that we need to look at how we build capability around using digital health technology. It really did not come, it wasn't comfortable with many of us. Most of us had never heard of Zoom pre-COVID, never mind use it. And this was something that professionals felt, if we're going to move forward with digital interventions, we need to look at building capability. At a systems level, it's important that there's existing IT infrastructure that supports the delivery of these programs. And particularly as we move now from the emphasis of care from the hospital to the community to facilitate integrated care, having the right IT infrastructure in place is critically important. The associated governance and also that leadership is really important. This was one quote that I think I'd like to highlight today because it spoke to the importance of engagement. So if you're looking to innovate, you need to try and engage as much as possible in advance, and not just land something on people, and be sensitive to all the fears and anxieties that people have. And I think, you know, as we move forward in looking at how we harness digital health, it's really important that we bring people with us. When we spoke to the healthcare professionals about the future and where they saw the role of digital health, they very much felt that we need to look at a hybrid model. We cannot just park face-to-face programs. They play a really important role, but that digital health interventions can really complement the face-to-face traditional program delivery and address some of those challenges that we heard about earlier. So finally, just to very briefly summarize, pivoting to online has very much been a journey. It's been a very exciting journey. It's been a very eye-opening journey with lots of learnings along the way. What we've learned is that it is feasible to set up and deliver digital cardiac rehabilitation programs in a very short period of time. Croí MySla provides important proof of concept, and this was one of the objectives of this Launch Care Integration Funds, was to provide proof of concept for interventions around prevention and management of chronic diseases. We've learned that it is possible to achieve the recommended lifestyle, medical and therapeutic targets that are associated with reducing cardiovascular risk in cardiac patients and improve health outcomes through digital means. We've also learned that digital programs are acceptable to both patients and healthcare professionals. And finally, have we reached our destination? We certainly haven't. I think we're a good bit down the road. I think the next steps to reach our destination are that we need to look at how we mainstream and upscale interventions like Croí MySla and ultimately deliver to what Sláinte Care is all about, which is about delivering the right care at the right time and in the right place. Finally, before I wrap up this afternoon, I'd like to acknowledge the efforts of the Croí MySla team, who worked incredibly hard to bring this program to fruition over a period in 2020. And I think sometimes, you know, we're now 2 years down the line, and you know, I think sometimes it's you forget about that initial phase of the pandemic and all of the adaptation and learning that had to take place. So it's been fantastic to work with this team of people, and thank you very much.
Well done, Irene. A whistle-stop tour, but really beautifully presented and so informative. And I'm sure that there will be people with comments or questions. So again, just to say to viewers, please do put them in the Q&A box. And when Irene joins us later as part of the panel, you'll have an opportunity maybe to tease out some of the issues that have come up for them in the delivery right across all of the stakeholders they worked with. So thanks again, Irene. We saw some testimonials earlier by animation where we met Jerry and David and Jonathan. And we had a quick look at Jonathan's story, but I'm now really delighted to welcome Jonathan live. Jonathan Walsh, you are very welcome, and thank you so much for taking the time to be with us. Jonathan, would you begin by telling us how you came to hear about this project and why you needed it?
Yeah, no, listen, thank you very much for allowing me to come on and I guess talk about my story and my journey with MySla. Yeah, so I'll start with the reverse of that. Why did I need it? So you probably heard from the video previously that just over 18 months ago, I suffered a heart attack. It came as a huge shock, a huge surprise. I'd had no previous cardiac issues or problems. There was some cardiac history in the family, but I completely overlooked it, never thought anything about it. And the next moment I'm in Galway Hospital having 7 stents to rectify the problem. So that's why I needed it. Obviously following the heart attack, I had a huge, you probably heard from the video, anxiety post heart attack was massive. It was almost crippling. And how I heard about the Croí MySla was I was referred to the traditional face-to-face cardiac rehab, and unfortunately, or maybe look at it now, fortunately, it was cancelled because of COVID. And I was referred to Croí from the HSE, and I was absolutely delighted to be, you know, selected for the program, and it came at absolutely the right time. So yeah.
Great. And Jonathan, what did your involvement entail? We've seen Irene lay out the program in kind of programmatic format, but practically and day to day, week to week, what did your involvement entail for you?
Yeah, so it was, first of all, it was really easy. It was really easy to access. The team would give you a brief before the program started, and every week you would attend the digital session. And on that digital session, there would be a huge, broad spectrum of people from different locations around sort of the Western continent and places, different conditions, different experiences. And it was about attending that, and on that session, there would be different specialists, from dietitians to physiotherapy to people, specialists talk about, nurses talk about medications. Prior to my heart attack, I'd never even heard of what LDL means. And now I'm, the MySla program, it gave me every single week something new to cope with the condition and the experience that he's been through. So yeah, no, extremely grateful for what was offered. So.
Good. And just in terms of one of the things that Irene mentioned there was about, access to broadband and Wi-Fi being something that maybe was one of the barriers. So did you have to access, or were you already set up with that kind of situation to enable you to participate?
I wouldn't say I was fully set up at the beginning, but I do have to say that the Croí team, from my own experience, the Croí team made it as easy as they possibly could. They talked you through the whole digital aspect of it. Prior to COVID, I don't think a lot of us had heard about what Zoom was or what the digital world meant. I think So it did take me a little bit to get into the swing of things, but like I said, the Croí team were there, they're really helpful. And what I did notice on the program was that there was a huge range of people from different ages and different IT literacy. Some people were literate, some people weren't, but people wanted that care, and they took the time and effort to come onto it. So yeah,
very good. Yeah. So for you then, looking back over it and thinking about it, what's the key outcome and impact for you from your involvement in the program?
I don't say this term loosely. The MySla program for me was a bit like being in the middle of the ocean and being handed a bit of a buoyancy aid or life jacket at the time. Prior to that, I didn't know which direction I was going to go into, and then I entered the program, and the impact was, it was actually life changing. It was, I just had you might have seen from the video, just had a new baby.
Yes, congratulations, baby
thank
Shay.
you.
How's he doing?
Shay. Oh, he's fantastic. Yeah, he's a bit older now, but he's great. But at the time, anxiety was high, depression, and the impact was I was able to reduce all the risk factors that I had. Irene put up a slide there with all the different risk factors, and unfortunately, I fell into the majority of those risk factors. But at the end of the program, my cholesterol was the lowest it's ever been. My blood pressure was under control. I knew a lot more about the condition and what I was dealing with, and I guess given the tools to be able to go day to day and manage that and live with it. So, no, very, very grateful for the program.
Great, and very well put. So, Jonathan, we're going to see you in the panel at the end, and again, I'm sure there'll be people with questions maybe to put to you. But thank you so much, and wishing you the best of health. But we'll talk to you later on when we get to the panel. Thanks, Jonathan.
Thanks.
So, as this project is a digital initiative, I am delighted to welcome Professor Martin Curley from the HSC Digital Transformation and Open Innovation team. Professor Curley, you are very welcome to our session. If you want to switch on your camera there to join us. No, there you are.
Great, thank you, Grania, and hello, everybody. It's a real pleasure to have the opportunity to address you today, and thank you so much, and congratulations on what a wonderful project and service, and brilliant to hear Jonathan's story. So I actually have a few short slides to talk about what we're doing at a national level and how this Croí project and CVD prevention and rehabilitation, where it fits, and actually how important it is. So by way of context, healthcare in general is about a decade behind other industries in adopting digital technologies. And in that, Ireland is very much a laggard. We're fourth last in the OECD in terms of the use of electronic health records. A recent future-proofing healthcare study put Ireland as last in Europe on telehealth, along with Serbia and Romania. So we have to acknowledge that we're in a pretty dire state. However, we are making lots of progress, and there's a massive opportunity to leapfrog. So we have lots of disruptive technologies all showing up at the same time: virtual and cloud and artificial intelligence and the Internet of Things. And hopefully you can still see my screen of what we've proposed for Ireland, and we'll shortly launch a new national digital health strategy, the core of which is something called Leapfrog and Stay Left, Shift Left. So we want to move from a healthcare system that's paper-based, that's presence-based, and is focused on the acute hospitals. And that's exactly what the Croí program has done. A home and community-based solution, remote monitoring, virtual, proactive, predictive, and preventive healthcare. And we have set a goal that we're going to move from a digital health laggard in Europe to a digital health leader by 2025. And we're building out a maturity curve with Maynooth University, funded by IDA and Enterprise Ireland, so that we can actually be guided on this journey and how we can actually measure our progress. Our whole strategy is very, very simple. It's called Stay Left, Shift Left. stay left is about keeping people well, or if you happen to have a chronic condition, you can be managed or rehabilitated best at home, as Jonathan was. And shift left is about finding interventions that move us very quickly from an acute to a community to a home setting. This is a little bit sort of, broader outline of what stay left, shift left means. All the time we're seeking interventions that deliver 4 outcomes, which are sometimes called the quadruple aim: better care and better outcomes, lower cost or better value, better quality of life for clinicians and particularly patients, and better experience for the patients and the clinicians. And as we're doing this, we're finding that not only can we do that, but we can sometimes do it an order of magnitude better, 10x better, or whatever. Here's an example of, some of the logos of organizations we're working with, from Medtronic and Roche and Centric Health and Croí, etc. will be on this. And we're investing our digital innovation budget, 70% of it is on this stay left. There is an enormous shift that needs to happen in Irish healthcare and global healthcare to actually better achieve outcomes and actually have a sustainable cost model. We're about to launch a vital signs automation system across 19 hospital wards. And this will make our hospitals far safer and better, and make it better for patients and nursing staff and clinicians. Across the country, we have a network of living labs. Today, we have about 50 living labs. And you'll see there, in Galway, we have an ongoing dialogue where we're having with Neil and the team to establish, the Croí CVD as a national living lab that can go from proof of concept to demonstrator and hopefully broad adoption. We're very much into, agile, and we've been working with Croí to explore how we could even move even faster. The very first week that COVID hit our shores, on the Tuesday, we actually demonstrated a prototype remote monitoring COVID device at the IIEA. And by Friday, we were prescribing this from St. James's in the Mater. And within the space of 4 to 5 weeks, this solution was broadly adopted across 30 centres. I think what Croí has done here, the results are really significant. And we'd really like to think about how we might rapidly scale this actually nationally. So when we talk about digital transformation, is rapid, coordinated digital change at scale across the entire health system. So we will launch a new national digital health strategy on March 25th, and we hope Croí will be there, and we'll be talking about this case study. But we have the entire ecosystem, and Enterprise Ireland and Science Foundation Ireland, or IDA, universities, working with us, and very large companies. And our story is now starting to reach global attention, where we're recently featured as the cover story on Healthcare Global. We've deliberately not been communicating in Ireland. We've been really working hard to prove the strategy, but now that the pandemic has at least dissipated for the moment, we're going to start to ramp up our communication. We're using a leading edge methodology. I had the privilege of chairing an EU advisory group for 7 years, and we came up with a methodology for Open Innovation 2.0. This is about actually how do you drive a structural change in an industry using digital technology. If you're interested in a short overview of that, I published a piece in Nature a few years ago, and it's a good summary. But we now have a full ecosystem working with us. This is actually just a snapshot of the ecosystem, and everybody is aligned around the agenda of stay left, shift left. Another technology that we've introduced very rapidly is RespiroSense from a company in Cork, PMD Solutions. A year and a half ago, this was just a shelf product. Now it's deployed in 22 acute hospitals, and it allows us to predict 12 hours in advance, for example, for a COVID patient of a hypoxic event, so we can intervene early. So we've moved from a system that just couldn't deliver a healthcare system You know, we still have systems, legacy systems that are trying to be delivered and they're 5 years late. Electronic health records are 10, 15 years late. But we know how we have proved that we can actually put in technology fast, effectively, and rapidly across the country. Related to this, I just want to mention one of our other living labs, which is with Centric Health and Roche. We've been monitoring 100 patients that have heart failure conditions at home for 6 months. We normally might have expected about 30 hospitalizations for 10 or 12 days at a cost of 12 to 14K. In the 6 months, we've just had one, and that's because a titration was changed for a patient, but they took 3 days before they started it and they ended up being hospitalized. But this is the kind of example, and very similar to Croí, you know, what we've been doing. This is an alive device with about 100 patients. We'll be announcing a national action plan called Stay Left, Shift Left 10X.
Okay, we seem to have lost Martin's link there, but I think he was...
On March 20, 10X intervention, 10X faster, 10X cheap, 10X capacity. Hopefully I'm back in here.
Yep.
Can you hear me now?
Yeah, we lost you there for a second, but you're back.
Right, but just to mention, and these are my last 2 slides, we're talking about Stay Left, Shift Left 10X as a national program. And the Croí CVD prevention or rehabilitation is a really good example of this. 6X improvement in physical activity, and we know this is crucially important to health and wellness. 3X improvement in blood pressure control, 2X reduction in anxiety, depression levels. So this is already a role model example, and we actually will be publishing the Croí example as one of the 10X examples that we share in the National Digital Health Strategy. So where does Croí fit into the broader plan? So we're working with Ken McDonald, who's the National Clinical Lead for cardiovascular. We have a significant workshop next week, and we are building what we call a capability maturity framework that will help us move from a reactive care to shift left to stay left, and then to very proactive healthcare, where it's about proactiveness, prevention, precision, prediction, and so on. And you know, very much we will be inserting the Croí roadmap or the Croí products and offerings into this workshop. The workshop will have presentations from, you know, Roche, from Medtronic, you know, from AliveCore, from Salasso, etc. But the key, the Croí presentation and methodology is something that we will immediately insert into this roadmap and look to see how we can scale. Just to mention this opportunity, we you know, had the privilege of chairing a session at the United Nations General Assembly last year. We're already planning for this year's UNGA meeting, and we have agreement from about 15, 20 countries about using Stay Left, Shift Left as the new paradigm. I think there'll really be an opportunity to showcase what the Croí CVD program has done in Ireland, and there potentially could be international pickup of it. So let me stop there, Grania, and hand back to you. Thank you.
That's really fantastic, Martin, and I think a lot of information, but also from the point of view of the report we're launching today, there is a clear pathway. Irene's last slide, wondering how to get mainstreamed, where to go, but it seems to me that you have very much included Croí MySla in your thinking around this much larger national digital strategy, and we look forward to seeing the launch of the Stay Left, Shift Left strategy, and the Leapfrog strategy that you described earlier on. I think gives us a very clear sense of all the work that you've been doing and that you have put into to create this space where not only will Croí MySla find its home, but actually it could be a model for other developments in this field. So look, thank you so much for that. And again, Martin, we'll bring you back in for the panel discussion. And again, there may be questions for you at that point, but a really, really interesting presentation and an overview with, I think, a 2025, 2030 target. It's very ambitious, but very needed, as we see from our current place at the lower end of the spectrum of where we should be in this field. So our final speaker today, before we invite all of our speakers and guests back for a Q&A, is Professor Liz Neubeck, Professor of Cardiovascular Health at Edinburgh Napier University. Liz is President of the Association of Cardiovascular Nursing and Allied Professions and an expert in digital health. Welcome, Professor Neubeck, and thank you so much for joining us. Could I invite you perhaps to share your perspective on the value of digital health innovations writ large, based on your experience and awareness of the evidence in this area, and perhaps maybe, some comment around the Croí MySla, and even a response perhaps to what Martin has presented just before you, because I think it speaks to your interest in this large field. I know you've a few slides, so I'll let you take it from here. Thanks very much, Liz.
Many thanks. So I'm slightly different in that I was an early adopter of digital health and have been trying to get people to invest in digital health for some years. So for me, COVID has provided a real transformative opportunity in that other people have seen the benefits. So I think Professor Wood highlighted at the start the challenges in access to recovery programs for people who've had a cardiac event and for appropriate prevention globally. We know that high-income countries have more cardiac rehab than low-income countries, but typically only about 50% of people globally are eligible for cardiac rehab are actually referred to it. So we had a challenge even before we were hit by changes to our lifestyle through COVID. And when we split this down, it's only about 30% of women go compared to 30% of men. And some of that is about the format that cardiac rehab is traditionally delivered in. So when we think about digital health and the potential for its transformation, there has been a lot of work over the last 15 or so years looking at how we might use digital technology to deliver a cardiac rehab secondary prevention program. The advantage of this transformation to digital technology is that we can offer tailored and personalized solutions, as Croí MySla has so well illustrated. And in particular, one of the things that we have found is that reasons people don't go to facility-based services is the difficulty in access, difficulty in parking, the times that the service is offered. If you have caring responsibilities, which is a major reason for women not attending, there are safety concerns in presenting yourself at a site. There's also challenges of distance, and in countries like Ireland and Scotland, where there's lots of rural communities, getting to a centre-based service is really a problem. I just wanted to highlight again, this was nicely encapsulated in Irene's presentation, that age is frequently cited as a barrier to technology usage, but in fact, in all of the studies that we've conducted, it really isn't a problem to encourage older users to take up technology and use it for secondary prevention and cardiovascular health, but you do need to think about resourcing. So access to broadband networks, access to the right sorts of equipment. Otherwise, we risk creating a greater divide, a digital divide, by providing it to people who can only afford it themselves. But at least 75% of smartphone users have downloaded an app to their device. So it's not something we should say we can't provide for this population who are typically older. We do have challenges of complicated data usage plans. And of course, when we're developing digital tools for older adults, we need to consider the vision and the design needs. And we also need to think about whether this needs to be perhaps based on a tablet or on a computer screen, because some smartphones are really small, or people have challenges with the small buttons. One of the interesting findings that we've noted over the last 15 years is that it's often helpful to provide a user manual, a printable user manual, either in a downloadable PDF or a printed document. And that gives people the confidence to know that they're not going to break any kind of system. So when the pandemic hit in March 2020, we did a review of the literature around how we should be considering building this connected home for people who might be living. At the time, we thought for maybe 3 months. We were optimistic. Now we're nearly 2 years. We recognise that access to these facilities is even more important. So our recommendations were around ensuring that people had access to medications, that they had somebody to contact, that their psychological health was attended to, that they had opportunities for exercise, whether they be home-based or in the community. We needed to provide financial resources to support digital technology. We needed to provide information about healthy diet, and we could potentially use wearables to connect and monitor, either with some of the technology that might monitor health status, such as portable ECGs, single lead ECGs, or with wearable trackers that might monitor how well people are exercising. And finally, one of the big challenges is that people have not felt comfortable to access acute care and usual care. So transformative programs were vitally important, but we need to keep the message going about the need to still attend hospital appointments if you are seriously unwell. So I think we can start to help people understand that more through the use of digital technology. So of course, you've heard all about Croí MySla. It embedded many of the principles that we recommended in our paper, and I think it's really gratifying to see that what we had predicted as being necessary has been shown to be of value in a well-developed program that looks at managing cardiovascular risk. And just a very brief conclusion, so we can go on to the panel discussion, is that yes, digital health can add to the suite of available options to increase access to cardiac rehabilitation. COVID-19 has been transformative, but one of the big challenges perhaps has been preparing the staff to deliver digital health. So as well as investing in the technology, we also need to invest in staff training, and we need to maintain these positive gains that we've had by investing in digital health and not going back to what people find comfortable and normal, but maintaining and moving forward with the technology and investment and development.
That's great, Liz. Thank you for that. Just before we move into the panel, I noted your comments around age not being a barrier, and certainly with other digital and tech-based interventions that we've seen in other programs that I've presented webinars throughout Sláinte Care and other integration fund projects. This is really a myth that has been knocked on the head, hasn't it? This idea that people over 65 are incapable of switching on their phone. I mean, we've seen people, you know, WhatsApp their kids in Australia within a week of the outbreak of COVID. So in fact, those old-fashioned ideas really do need to be knocked on the head. That's not to say, as you pointed out, that people mightn't need a better smartphone or better broadband, but certainly age in itself is not a barrier. The other thing you mentioned, and I might get you to say a few words about it now, is around this gender differential. Would you just speak a little bit about that, because I'm very interested in it?
Yeah, of course. So we traditionally provide cardiac rehab in a circuit-based environment. So we have great programs, and I think Croí has got a really interesting model where we have the interventions of the nurses and the whole healthcare team nested around a more traditional gym-based model. When we look at free living people who go to a leisure centre, in fact, there's quite a gender divide in what people participate in. So we've looked at leisure centre data in Northumberland, and women tend to go to classes. And this is probably no surprise when you hear it. They tend to go to yoga, they tend to go to aerobics type classes, whereas men tend to go to the gym. And they do circuits and they do, you know, they use equipment. But we haven't applied those logical lessons into cardiac rehab. Now, there's multiple reasons why women don't go to cardiac rehab. It's predominantly men there, so they may not feel comfortable attending a program that's all surrounded by men. They may have other responsibilities. But one of the things that's really interesting about digital health is that women are key users of digital health, and particularly when you think about gaming, women are more likely to game. And by this, I'm thinking about things like Candy Crush. Wordle is the current game that's going around the world. It's women who are predominantly using these technological tools. So it may be that we can increase access for women, but it's a huge problem. And I think it's something that has to be recognised that we don't really address well enough on a global level.
Very good. That's really interesting. Liz, thank you so much for joining us and for your presentation. So Liz is going to stay with us on the panel, and I am delighted now to welcome back to the panel Professor David Wood, Irene Gibson, Jonathan Walsh, Professor Martin Curley, and also joining us at this point is Neil Johnson, the Chief Executive of Croí. Irene, can I come back to you just a little, if I might, to begin with? We've heard a lot about the successful outcomes of the programme, but can you share with us what some of the key challenges were that you had to face and overcome?
Sure, Grania, and I guess there were challenges at multiple levels, and of course digital transformation is a complex, multifaceted process. The intervention that we wanted to deliver is a complex intervention. And I think for us, it was really about trying to find the right digital tool to deliver the intervention. And at the outset of the pandemic, I mean, all healthcare professionals, different aspects of health service we were all grappling with adjusting and pivoting and trying to select, what would work. Because I think one of the things that was really important to us was delivering a high quality program that was going to meet with the patient needs.
Yeah.
And, that was certainly a key challenge. I think, when you're looking at transforming your service, you also have to look at, your capacity to do so. With the Sláinte Care integration funding, I mean, it was a very defined project. It had timelines, time was of the essence. So we really felt under pressure to respond, not least, of course, because of the fund, but also because of the needs that patients were presenting with. And I mean, you've heard Jonathan speak to how much the program, what difference it made to him. So, I guess one of the advantages when you're under those time pressures is that decisions get made quickly. And, Liz mentioned there about the paper that she published, and we constantly found ourselves, after doing loads of research, coming back to that paper and looking at, well, simplicity is key here. So working with our sister organization in the NIPC, we looked at, a very, very simple platform. I mean, there's all sorts of really sophisticated tools out there, but we felt we had to be realistic. We had to acknowledge where our skill set was at and what we could do, within the confines of the situation that we found ourselves in. With every challenge, of course, there are opportunities. We've learned a huge amount from this experience. But I think one of the things that we've learned is that, when you're looking to pivot, which is a very popular word, and move services online, that really it's more than just about the healthcare professional themselves. It really requires engagement with lots of stakeholders. And of course, central to that, the patient has to be at the center of all of this. But it does require tech experience. And, Liz mentioned this as well, as healthcare professionals, we do have to be equipped with the skills.
Yes.
And it's very different delivering something online to actually, maybe delivering a health promotion session in a group with patients. It's a very different way of delivering care. So lots of challenges. And we've outlined, I think, some of this in the report, but certainly lots of opportunities as well.
Very good. And Aaron, just before I move on from yourself, we've had a question in from one of the participants, one of the viewers, asking about, people with communication difficulties, for example, post-stroke aphasia or cognitive communication disorders, dementia even. Have any of those populations been included in the programme or its evaluation? An interesting question.
Yeah, I mean, I think it's an excellent question, and certainly on our programme, not that I'm aware of. I think, certainly, as I said, our programme was delivered over a very short time period. I would imagine if this programme was continuing, then certainly, we would have lots more of individuals who are living with those challenges. I don't think digital health interventions necessarily exclude those individuals. I think it's how you set up and design your program to be inclusive. I think if we were doing this program again and we were, looking at specifically being inclusive of maybe individuals living with stroke, then I think we would work with stroke patients to ensure that we develop the program to tailor it to their needs and deal with the challenges around dysphasia and so on.
Very good. And Liz, I see you nodding your head. Have you international evidence to support this?
Absolutely. And not so much with dementia, but certainly apps have been deployed and successfully help people with cognitive impairment. And of course, you have to remember that many people with a cardiac condition are suffering from some degree of cognitive impairment, usually around executive function and recall. So that's why we provide written information. And of course, that can also be provided digitally. But I think, and I don't think it's possibly come out as strongly as it could have done, that the Croí MySla program is very much inclusive of the family. And that is, of course, where you get support for people with special additional needs. We need to engage the family, and people live in, in a family unit who have similar risk factors. So in the program, I believe, and maybe I'll hand that back to Irene to answer, very much it's about making lifestyle risk changes yourself and with your partner and their other family members. And therefore, that will address some of those individual challenges, or carer, of course.
Very good, very good. Thank you. Could I come back to you, Professor Wood, if I might? The 105 patients who were referred to the program, from your view of looking at the program and its outcomes, what do you think are the most significant outcomes for the patients?
Well, I would like to put my answer in a context here, in an Irish context here, because actually Ireland is, I think, one of the most progressive health systems that I have ever worked with. The traditional hospital and primary care silos are now being added to with community-based hubs, and seeing the movement of care of patients with cardiovascular disease, diabetes, and so on from the hospital, not into primary care as such, but into these community hubs, which contain the appropriate staffing, nurses, dietitians, physiotherapists, who are able to deliver the kind of care that these patients require. And that's exactly the sort of setting where the Croí MySla program fits perfectly, both face-to-face and delivered digitally. So Ireland is already creating the environment, the healthcare environment, in which one can deliver comprehensive preventive and rehabilitative care to all of these patients. And what are the most important outcomes? I think the most important outcomes are the lifestyle changes that this program helps patients to achieve. But it is also important to say that beyond lifestyle, it's also necessary to lower that LDL cholesterol, control that glucose, and reduce that blood pressure, and to be adherent with medications. And it's that comprehensive view, holistic view of care that the Croí MySla program provides.
Very good. Thank you for that, Professor Wood. Jonathan, bring you back in here. Jonathan, based on your experiences in the program, do you think that programs like this should be available to all the patients? And we're talking wider than just in the Western region. What's your overview of the program?
No, absolutely. I think it should be. I think as the COVID-19 pandemic was a turning point in the digital sort of technology world, I think everyone moved to that style of communicating, and people got so used to it. And I think, absolutely it should be available to everyone. I think when I look back to my program and my own experience in the group that featured my time on the program, was something that sticks with me. Is there was a person that lived 1 hour away from the facility both ways, and she found it very difficult to get. She wouldn't have been able to attend had she been physically going to that, because she didn't drive herself. There was family members who were out working, just the support network wasn't there. But she did mention the support network was there to to show her how to work Zoom or the laptop. So I think, I can vouch for myself because I'm young and, technology minded, but it was so accessible. So it should absolutely be accessible to people because the program is accessible.
Yeah, exactly. So. Very good. That's great. Thank you very much. Back to you, Professor Curley, if I could. Would it be true to say that, the COVID-19 initiatives or things developed during COVID-19 have actually fast-tracked some of the digital transformation wishes and desires that you outlined earlier? I mean, is that true to say, or is that just something those of us as outsiders seem to think this stuff has galloped suddenly into the forefront? Do you think it's part of just the speed with which to make changes? You were talking about some initiatives where, practically thought up on a Friday, tested the following week and up and running within weeks of that, which is so unusual. What's your view on that, Martin? You're on mute there, Martin. Just unmute yourself.
Yeah, thank you, Grania. Apologies. Yeah, very much so. Somebody who might be familiar with the excellent book called Big Bang Disruption. We talk about COVID really as, a catalyst or a stimulus for enabling Big Bang disruption. And Big Bang disruption happens when the typical technology adoption curve, which Everett Rogers popularized in the 50s and then Geoffrey Moore popularized in the 80s and 90s, is rapidly pulled in. So I think it was really down to necessity as the mother of an invention. And for example, a real challenge in Ireland, there was incredible resistance to use of electronic prescriptions, and it had been resisted strongly for multiple stakeholders for 10 years. And we were able to pull together with the Department of Health, and in 2.5 meetings with the Irish Pharmaceutical Union, our pharmacy union, the ICGP, and other parties, we got an adoption decision and we were able to turn it on. We went from about 500 electronic prescriptions on day 1, but on day 3, we were at 20,000 prescriptions electronically being transferred, and quickly went to over 50,000. So it has been, every cloud has a silver lining. It has really created the environment where we can much more rapidly scale digital, and people accept it.
Yeah, for sure. For sure. Thanks, Martin. And I know myself, never again will I be queuing up in my GP's office for a repeat prescription. That things really have changed over COVID, and many of us thinking we're not going back to that normal, whatever that normal was. I have another question here, and I think it's from one of the people who was on your program, a chap called Niall Nugent. He's saying, what's next for MySla? It really should be offered again, as it really helped him. Can I go to the CEO of Croí MySla? Your hopes and ambitions? I mean, Martin has maybe sketched out the big picture into which Croí MySla fits. What are your hopes and ambitions for where this very successful programme should be headed to next? Neil, over to you.
Thanks, Grania. Well, I think from a Croí perspective, this was a case of when needs must. My colleagues pivoted to digital delivery virtually overnight. That this was originally to be a face-to-face program. So I think, we can't let today pass without recognizing and giving credit to them for an exemplar really of what can be done when you have people with the right attitude and the right approach to the task at hand. And we did see that, of course, in many areas of healthcare during COVID. I think what we've learned is that cardiovascular disease prevention and rehabilitation can be delivered virtually. Barriers can be overcome, and the benefits, the significant benefits for all stakeholders far outweigh any of the negatives. I think this project is further evidence of the importance of multidisciplinary engagement in cardiovascular disease prevention. This has been the hallmark of all the work we've been doing in Croí for so many years. And there's a need to invest in this guideline recommended intervention that we call cardiac rehabilitation. For the critics or the skeptics who say, these outcomes are a once-off, the numbers are small, or whatever, I'd remind them that Croí has over a decade of experience of delivering this type of intervention, and all of our programs are yielding the same positive outcomes. The only thing that's different here is that this is done virtually and digitally. And the reality is that digital health, so in terms of what's in the future, digital health is here to stay. And patients will demand this type of engagement. They are beginning to do so already. The future of this project, MySla, now is in the hands of Sláinte Care and the HSE. This was an innovation project. We demonstrated a model of delivery which should be a part of any modern health service. And I think it's incumbent on Sláinte Care and the HSE, and I hope some of them are listening into this conversation today. It's incumbent on them to ensure now that this model, maybe not necessarily our particular product, maybe we know what adaptations or changes, should be integrated into mainstream healthcare. And as already been alluded, we have an opportunity, a unique opportunity in Ireland now through the community hubs, because they're the ideal platform for this type of program. Absolutely. And it is entirely and fully aligned with the philosophy and the principles of Sláinte Care about right care, right time, right place. The only barrier right now are the healthcare decision makers who have the opportunity to really make a decision here that could be hugely beneficial to patients. So it's just about deciding to do it. And if a small not-for-profit organization in the west of Ireland can demonstrate a digital delivery model such as this, why can this not be mainstreamed into our healthcare system?
Very good. And of course, that was the initial purpose of all of these Sláinte Care funded, was to take an idea, demonstrate it, and the promise was that those that are successful, every effort would be made to mainstream them into mainstream provision. Not putting Martin on the hot spot here, but it's certainly clear, Martin, from what we've heard, there are outputs, there are outcomes, and from what I've heard from you already, you're very open to this. Would that be correct, Martin?
Yeah, very much so. And, I would think, Sláinte Care, everybody agreed to it, but nobody was really driving it. We don't have a Sláinte Care director. There really wasn't a lot of thought put into actually how we could do this on a coordinated, large scale approach. And that's why we actually have developed a transformation strategy that is bigger than the HSE, bigger than the Department of Health. And we're using this Open Innovation 2.0 methodology to actually implement Sláinte Care. Actually, I think we need to be realistic. The HSE or the Department of Health aren't actually designed to implement large-scale change. They don't have the skills to do it. But if we actually work together, we can actually leverage the people and the organizations that have those skills. And the HSE and Department of Health have some great people, and as an organization, we're very much focused on real-time delivery and operation of our healthcare services, and the important and urgent always gets precedence over the extremely important. Not the words. I think that.
Okay, we're losing Martin again there.
Around where offerings that Roche or Centric might have are synergistic and complementary to what goes to what's level. So I think we now are a pretty significant change. And I think we'll be holding up what Croí does as an exemplarily diffuse that nationally.
Very good. Okay, sorry, Martin, you're breaking up on us there, but the gist of what I'm hearing is very positive and is, I think, a good response to Neil's ask, and also, I think, a good response to what those implementation funds were originally for, to take the best ideas from practitioners and see what could be done to improve, reform, and get better outcomes for patients, but also I think for many of the clinicians who wanted to do their work in a new, exciting and more innovative way. And it would seem from what we've heard today and over the lifetime of the project that this project is now ready and ripe for the mainstreaming journey. And it sounds from what Martin is saying that within the digital transformation space, this is where it fits, it's its proper family home, and he certainly is open to supporting that. And it would seem even the seminars and conferences over the next couple of weeks looking at this issue, that Croí would have a space in there to be able to further their case with, I think, Martin's support. So again, thank you for that. We have a number of other just positive comments coming in from participants welcoming this, asking it to be rolled out nationally, asking that the barriers be removed for patients, including digital education for participants and staff, so that things aren't just landed on either of them. And that's the kind of the lead-in plan for any of these new technologies, enabling them to be taken up in a way that maybe Irene outlined about the preparation. I thought her point about the PPI involvement, always so important, from the thinking of something to have a public patient stakeholders grouping, so that you can meet the needs of participants. And as I say, we've have a couple of them on bearing testimony to the programme, along with what we've heard from Jonathan on the panel. Can I take this opportunity to suggest that those who have been participating in this session might actually read the report. We put the link to it earlier on in the chat function. I want to thank all of our panelists here today, particularly Professor Newbeck and Professor Wood, for joining us at short notice in the place of Professor Bill McAvoy and Dr. Susan Connolly, who have also given of their time and support to the work and to the webinar. I want to thank the background team, Adele Keneally, Dr. Lisa Hines, Maureen Boyle, Bridget Chisti and Annie Costello, the funder Sluntacare and the Sluntacare Integration Fund and their team for their supports, and to all of you for joining us here today. Finally, I'd like to extend my thanks to the most important groups here, the participants who attended the Croí MySla, and the healthcare providers who supported and referred their patients to the programme, the Croí Health team who delivered the programme with such great success despite all that we were all facing in 2021. Finally, I want to thank you, the viewers, for tuning in. I hope you enjoyed the session. I've certainly enjoyed meeting with all of these practitioners and listening to and hearing the lessons and the plans for the future of Croí MySla. The report is now officially launched. Best wishes to you all and goodbye from me. Thank you all very much.